Thank you again to the course chairmen for this wonderful invitation. It's a pleasure to discuss the use of Alif in adult spinal deformity. I think this blends in well with the previous discussion that we just had. The objectives is to discuss adult spinal deformity and how sagittal malalignments causes disability, which has been reviewed very well by a number of speakers, how spinal pelvic parameters help us guide alignment goals, and the use of Alif in achieving sagittal realignments with some case examples. Adult spinal deformity has come a long way, as been demonstrated, and now we know that sagittal malalignment and disability go hand in hand. Landmark papers by Steve Glassman and a lot of work by the International Study Spine Group led by Frank Schwab has shown us this. Spinal pelvic parameters such as pelvic tilt, PILL mismatch, and SVA not only predict patient disability, but help us assess appropriate therapeutic decision making. And we also know that the severity of the symptoms get worse with progressive sagittal balance. We also know that reconstruction and correction of the malalignment improves health-related quality of life outcome measures. Especially improvements in the parameters of pelvic tilt, SVA, and PILL mismatch do improve the outcome measures such as ODI and beyond. This was shown by a very nice paper led by Justin Smith from the same group. We also now know that we have certain alignment goals in mind. It has been published and touched upon earlier. Keeping the SVA less than 5 centimeters, getting our pelvic tilt, which is a compensatory mechanism, below 25, and proportioning our lumbar lordosis to PI, and also cautioning the fact that there must be some age correction for how much correction we're trying to give to our patients, because the elderly are not going to tolerate as much correction. Achieving alignment goals surgically becomes very important. You have to determine the flexibility of the patient and whether this is a fixed deformity or not. And you have to do surgical planning to achieve this. In the patient over here, you could see that she's using maximum number of compensatory mechanisms, such as retroversion of the pelvis. And you can see that on the AP x-ray. There is no pelvic inlet over here. She's flexing her hips and knees, and when we take that away, she decompensates even more. So this patient has a PILL mismatch of 53 degrees and an SVA of 19. Determining flexibility, I usually use a Scout CT, get a supine x-ray, and sometimes use bolster x-rays in a supine position. You could see that this patient has a good fusion mass in the instrumented region. However, there is an open disc at 5'1", which gives us a window of opportunity. So after flexibility has been determined, then we have to try to choose what kind of approach we're going to use for this patient. The Schwab classification of posterior osteotomies has been reviewed very well. Usually patients like these require at least a grade 3 or grade 4 osteotomy. As we know, our osteotomy choices are variable. Smith-Peterson osteotomies can give us up to 15 degrees per level, anterior, posterior, probably about been coded to give us the same, and then PSOs, depending on the grade, can give us more and beyond. So for this patient, we chose to use that window of opportunity. After doing simple releases posteriorly, we used a hyperlordotic Alif cage at the anterior portion. And with intraoperative measurements, we were able to see that we reached our alignment goals, so we did not have to go any further for this patient, and we did not have to do a 3-column osteotomy, which does carry some higher complication risks. So with some simple posterior ponta osteotomies and also a hyperlordotic Alif, we were able to achieve a a balanced spine with SVA of going from 19 to 13 and pelvic tilt correcting as well, as you can see in the AP. As you can see, she anteverted her pelvis, regained some thoracic kyphosis, which was used as a compensatory mechanisms previously. And most importantly, the clinical outcomes, including her walking tolerance, improved and the back pain. This is not a new experience. There's been publications on use of hyperlordotic ALIFs can produce large correction in the magnitude of posterior osteotomies. And most importantly is that most of the correction is achieved in the lower lumbar segments. And this creates the natural anatomy and the lumbar distribution of lordosis. And there was no increased complications in the rate of than traditional ALIF. This is a second case example. The difference between this patient is that this patient has had several surgeries prior, which leaves the lower levels, the 4-5 and 5-1, completely fused. The initial laminectomy that he had took care of his neurogenic claudication. However, because of increased back pain, he received a 4-5 to S1 TLIF, and when he did not get better, the instrumentation was removed. He came into the office using walking sticks because he could not stand up straight. He did not have neurogenic claudication, but just back pain, and walking tolerance was about 1 to 2 blocks. You can see in this patient, he's also using the compensatory mechanisms, including thoracic hypokyphosis, retroversion of the pelvis, and the CT scans show us that there are fusion mass around the peak TLIF grafts and also some anterior osteophytes, a questionable fusion at 4-5, probably a pseudarthrosis. However, he does have a very large SVA and a PILL mismatch of 59. So how would we approach this patient? Very importantly, we have to determine the flexibility. We can see just by lying the patient supine and using a bolster, we get about 15 degrees, probably not enough to get him to where he needs to be. So if you choose to only do posterior Smith-Peterson type osteotomies, maybe the magnitude of correction might not be enough. A PSO would be a good option. It has high complications, and in my opinion, sometimes puts the apex of the lordosis a little high. Lateral antibodies would potentially, in the upper lumbar spine, which are open, could help you. However, there could be a question about the magnitude of correction that they need and the harmony of the correction. And the lower levels are already fused. So the question of harmony in correction becomes important, keeping the lordosis low. We don't know yet if that might decrease our PJK rate and whether it gives us better compensatory mechanisms that come back. And we have to remember the PSOs are not perfect. Lordosis is not usually physiologic, and most of the lordosis should be at the lower lumbar spine. As demonstrated over here, there's a high UIV angle over here, and a great paper by Dr. Lewis that was just presented showed us that that could increase our fracture rate above. So we chose to do an anterior osteotomy with removal of the TLIF cages and placement of hyperlordotic ALIFs at 2 level. I staged this surgery and we stood the patient up. He has about 40 degrees of lumbar lordosis already from the 2 level ALIF. And by doing the posterior instrumentation and simple releases, we did a ligament reconstruction at UIV +1. He was able to achieve the correction that he needed. The lumbar lordosis of about 64 degrees was achieved, and the PILL mismatch corrected. And we could see that the compensatory mechanisms in the pelvis also corrected down to 8 degrees. Most importantly, his outcome measures all improved, and we were able to also correct the slight coronal imbalance. So in conclusion, Alif in achieving sagittal realignment can be a powerful tool in restoring sagittal alignment, and potential advantages including placing the lordosis in the lower lumbar spine, long lever arm for correction, and obviously the potential disadvantages. Second approach, I use an approach surgeon, so I need a second surgeon to perform this surgery, and also complications that could be related to approach, such as the very small reported rate of retrograde ejaculation and other vascular issues if your approach surgeon is not very experienced in that kind of thing. So thank you.